TaxAct's filing software and live tax experts can help small businesses easily knock out their taxes. Actually, our experts can help you find deductions and credits for any sized business. Itty-bitty businesses, medium-sized, really big, mid-sized, small businesses, companies with 0 employees, and mom-and-pop conglomerates. Yep, our tax experts can help all of them. TaxAct. Let's get them over with.
This is Addiction Medicine Journal Club. I'm Dr. John Keenan.
And I'm Dr. Sonya Tredici.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. This is a roundup episode, so we're going to summarize our last 10 articles that we did kind of in a high-yield fashion. Are you ready to get into it?
Totally ready. Yeah. If you're too busy, if you don't have time to listen to 10 podcasts, you can just listen to this one podcast. That's all you'll need.
All right, let's do it.
All right. So I'm going to start. This was episode 61, and the article was called Comparative Safety of In Utero Exposure to Buprenorphine Combined with Naloxone versus Buprenorphine Alone. So addiction in pregnancy is common, as we all know. It's found in about 8.2 per thousand pregnancies, and buprenorphine has been combined with naloxone as an abuse deterrent, although the efficacy of this is unproven. But naloxone has not really been officially tested in pregnancy. And past guidelines recommend that pregnant people be switched to buprenorphine alone from buprenorphine. Despite this, as you know, many pregnant people and fetuses have been exposed to naloxone without apparent increase in adverse outcomes. And the goal of this study was to assess the risk of adverse neonatal and maternal outcomes associated with prenatal exposure to buprenorphine and naloxone compared with buprenorphine alone. So pretty simple question. It included a really big group, 9,537 pregnant person fetal dyads exposed to buprenorphine, not methadone, and not having any other major congenital anomalies that were known, or any known exposure to teratogens or methadone. 70% of these pregnant people had opioid use disorder, 25% used tobacco, and only 15% received all recommended prenatal care. So a group that did not get adequate prenatal care. They looked at people receiving buprenorphine naloxone and compared them to people receiving buprenorphine alone, or who switched to buprenorphine in that first trimester, which mirrors clinical practice. The outcome, John, was primary outcome, major congenital malformations and cardiac malformations. And the neonatal outcomes were low birth weight, neonatal abstinence syndrome, NICU admissions, preterm birth, respiratory symptoms, small for gestational age, those kinds of neonatal health outcomes. They also looked at maternal outcomes like cesarean delivery and severe maternal morbidity. So pretty simple trial. I thought it was valid. It was a prospective cohort study rather than a randomized clinical trial. So there's a risk of the two groups being different at baseline. They did a lot of adjusting for the confounders to try to create some similarities try to create similar groups between those who were given buprenorphine and those who were given buprenorphine naloxone combo, since the two groups may have been different at baseline. Multiple sensitivity analyses were also done, and the outcomes were very clinically relevant. The most important thing, though, is that this study adds important data to the literature, increasing the number of buprenorphine naloxone exposed dyads reported by tenfold. This is just a huge data set to a very important and complicated question. So it allows more precise estimates regarding the risks evaluated in those prior studies, as well as greater power to consider a broader range of relevant safety endpoints. So a really great trial. The results. Both neonatal and maternal outcomes were either the same or slightly improved through treatment with a combination of buprenorphine and naloxone compared with buprenorphine alone. The primary outcome, which was percent of births with major congenital malformations, was 5.2% with buprenorphine naloxone exposure and 5.1% in those exposed to buprenorphine alone. The second primary outcome, which is major cardiac malformations, was 1.4% in those exposed to buprenorphine and 1.3% in those exposed to bup alone. These numbers were considered statistically the same. And so basically, there was not any statistically significant difference between those two groups. So will these results help me in patient care? They definitely will. My patients are similar to those in this study, and the outcomes are the ones that my patients care a lot about. congenital malformations and neonatal abstinence syndrome are something that pregnant women worry about. The benefits of buprenorphine compared to buprenorphine alone outweigh the harms in this study. There was no data on what happened to the pregnant person if they chose buprenorphine naloxone compared to buprenorphine alone in pregnancy. So we don't have data on relapse or opioid use. This study did kind of change my practice because if a patient asked me which would be better, I now say probably they're the same, but if you have to choose buprenorphine naloxone. It's likely a little safer for your pregnancy, but basically they're the same and you can choose whichever one you want. I don't recommend that patients switch unless they want to, and especially not if it would destabilize their treatment. So, John, did this paper change your practice at all?
I think it just kind of reinforces my practice with this is if it ain't broke, don't fix it. I've just learned this as a primary care doctor, just leave it alone unless it's causing harm. And I think for these patients, I've seen too much destabilization with switches. So I tend to kind of leave people on whatever they're stable on.
All right. Ready for the next article?
Yeah. So this was episode 62. So it was oral versus extended release injectable Naltrexone for hospitalized patients with alcohol use disorder. It was from JAMA Internal Medicine from April of 2025. So the clinical question here was that for hospitalized adults with alcohol use disorder, is oral naltrexone or extended release injectable naltrexone more effective at reducing heavy drinking days? A little bit about the methods of this. This was an open label randomized control trial. It had a pretty good size of 248 hospitalized adults admitted with alcohol use disorder. Adults were randomized 1-to-1 to oral naltrexone in the form of a daily tablet or extended release injectable naltrexone with a monthly gluteal injection. Subjects in the trial were followed for 3 months with major endpoints that they measured included a number of heavy drinking days, hospital and ED visits, medication adherence, alcohol-related problems, and healthcare costs. In terms of results, kind of in a very positive manner, both groups actually showed reduced number of heavy drinking days substantially. So in the oral group, they dropped from 66.7% to 27.4% heavy drinking days. So that was a drop of 38.4%. In the injectable naltrexone group, they dropped from 70.7 to 23.8% heavy drinking days. So it was a 46.4% drop. When you actually looked at comparing the two groups head to head, there was no statistically significant difference between the two groups. So oral and IM naltrexone in vivo situations performed very similarly in terms of reduction of heavy drinking days. Not surprising, the injectable group did have better adherence, which is actually kind of interesting. So even though they had statistically significantly more adherence, they didn't outperform the oral group. Hospital and ED visits were similar between the two. The only difference was that the cost was much higher in the injectable group. So, cost is such a funny thing in the United States where it's almost like funny money where someone's cost is $10, someone else's thousands. But the median cost for treatment in this was almost $5,200 or a little over $5,200 for the injectable treatment versus $1,600 for the oral. So substantially difference in cost. I think that the clinical bottom line for me here is that both oral and injectable naltrexone are very effective at reducing your number of heavy drinking days. Hospitalized patients are a captive audience, so I often like to engage patients in starting these medications there if possible, especially at the time of discharge. This would definitely show that oral naltrexone appears more cost effective, but it does kind of have a data point that if you have a concern regarding adherence, maybe consider the IM naltrexone.
Yeah, I like this study because I do have patients who are reluctant to do the IM naltrexone, both the inconvenience of all the different office visits they have to come in for and just they don't want to get the big shot. So if the oral works similarly, then I'm very happy to hear that. All right, ready for our next article?
Yeah, let's do it.
Episode 63, Buprenorphine Dose and Neonatal Opioid Withdrawal. This was a study in the American Journal of Addictions called Is Buprenorphine Maternal Dose Associated with Neonatal Opioid Withdrawal Syndrome Severity? So it's a theme with the last one I did in terms of severity of NOWS. It's just important because having a newborn sick with neonatal opioid withdrawal syndrome is one of the pregnant person's main concerns when they're on opioids. This association between maternal methadone dose and NOWS is established, but data on the association between buprenorphine dose and NOWS has not been as well studied, and data has been a little conflicting. So this was a retrospective study done to investigate the impact of parental buprenorphine dose on NOW's duration, treatment needs, and birth weight. So basically, is the dose that the pregnant person is taking related to the NOWs that the baby has after it's born? It wasn't a huge study. It had 80 full-term infants born to mothers who received buprenorphine during pregnancy and who all had NOWs. They divided maternal buprenorphine dose into 3 categories: low, medium, high, and compared the severity of the neonatal opioid withdrawal in those 3 groups. Outcomes were number of days, and they used a measure called the Lipsitz score. They looked at morphine dose that the neonates got, length of treatment, length of hospitalization, time to regain birth weight. The one thing that was a little odd is this was a French study, and I guess they use a lot lower doses in buprenorphine. So for them, anyone on high-dose buprenorphine was considered greater than 12 milligrams a day, which for us is like low dose. And their low-dose buprenorphines were on less than 2 milligrams a day, so 1 or less a day. Medium dose was 2 to 11 milligrams a day. So this was very low-dose buprenorphine overall compared to what a lot of my patients are on, 16, 24 milligrams a day. It was a good trial. The design was good. I thought it was a little small because they only had 80 infants, and then the 80 infants had to be divided into 3 study groups for comparison. And they also, I thought, didn't have enough data for all the pregnancy factors like other medications, mental health, socioeconomic factors that contribute to the severity of NOWs. It's just a lot goes into it beyond the opioid exposure. And the other thing is that, as is the case in many trials of opioid use disorder in pregnancy, they just looked at how the buprenorphine affected the baby, but nothing about how the pregnant person did. So if you really are trying to do a risk-benefit analysis, you have to know the risks of a lower buprenorphine dose as well as the benefits in terms of NOW's severity. So I think that was something that it was lacking. But I still think it was a good study and really good data. So the bottom line is that the increased doses of maternal buprenorphine are correlated with increased duration of NOWs, maximum doses of morphine that the infants required, and length of stay in the hospital. So for the low-dose bupes, that was like 1 milligram a day or less. Duration of NOWs was about 3 days. For intermediate dose, it was about 7 days, and for high dose, it was 17 days. That is very long. Secondary outcomes, including number of days to symptom onset, duration of hospitalization, infant morphine dose, those all also correlated with the maternal buprenorphine dose. So in terms of how I'll use these results, the bottom line is that the higher dose of buprenorphine during pregnancy correlated with more severe episode of neonatal opioid withdrawal. It gives support to pregnant people who may make the decision to reduce buprenorphine doses during pregnancy. Although it's not a strong enough study, there's too many weaknesses in the data to make a blanket recommendation that we should all try and reduce the dose. And actually, many pregnant women increase their dose of buprenorphine in pregnancy due to kind of different pregnancy physiology. But if a woman says she wants to reduce her dose, she's very stable, she's really concerned about NOWs, that could be an option for her throughout the pregnancy. John, have you ever offered that to patients or had patients reduce their dose of buprenorphine when pregnant?
Actually, I don't think that's ever come up with me. And I do take care of a fair number of women that, either are referred to me that are pregnant with opioid use disorder or, become pregnant during treatment. And I think most of the time, I think the idea of reducing a dose is very anxiety provoking. In fact, I think often the guidance they're given is that they might need a dosage increase during pregnancy, or at least that's what I've had a lot of OB colleagues kind of write out to me to recommend from their perspective. It's amazing to me that the high dose is only 12 milligrams. Like 17 days for NOWs that's incredibly long. I almost wonder if this kind of reflects possibly, like a societal difference in how it was treated, with how long the person was in the hospital. I just don't see NOWs babies in the hospital for 17 days.
Yeah, it's definitely a different setting for sure.
Yeah. Interesting though.
But it was very interesting.
So are you going to bring up that conversation or are you going to let the patient initiate that?
I don't suggest it unless the patient themselves says, is there anything I can do to reduce the NOWs? And I do have one patient who's gone through several pregnancies with me now, and every pregnancy she's reduced her dose of buprenorphine down pretty significantly by the time baby's born, and then ups it again postpartum. And it's worked out great for her.
Interesting. All right. So episode 64, this one's kind of a big change up for us. It's addictive screen use trajectories and suicidal behaviors, suicidal ideation, and mental health in U.S. youths. It's from JAMA from just this past July of 2025. The clinical question is, are patterns of addictive screen use, and they talk about social media, iPhones, video games linked to suicidal thoughts, behaviors, and mental health symptoms in adolescents specifically. So this was a longitudinal cohort study. It was very large, and it was out of this ABCD study, which kind of has a target population of ages 9 to 14. And there was almost 4,300 adult or adolescents in this study. There was 4,285. They measured addictive screen use over 3 years and assessed suicidal ideation and behaviors, and also internalizing and externalizing mental health symptoms at age 13 and 14. So looking at the effects by the time they hit kind of early teenage years. They kind of created these multiple different trajectories of screen use, and it was low, increasing use, and high use. And so it kind of was answering or trying to attempt to answer a question that I think a lot of us that take care of adolescents wonder is this harmful as we kind of predict it is? The results of the study was interesting. So high or increasing screen use was associated with elevated risk for suicidal behavior and ideation. When you kind of broke that down, increasing social media use had a relative risk of 2.14 for suicidal behaviors and a relative risk of 1.46 for suicidal ideation. High video game use had a 1.54 relative risk for suicidal behaviors and 1.53 relative risk for ideation. And then high mobile phone use had a relative risk of 2.17 for suicidal behaviors and 1.50 for ideation. So interestingly, social media, iPhones or mobile phones and video games all increase the relative risk of suicidal behaviors and ideation. When you got to internal and externalizing symptoms, they were also higher, in particularly the high use trajectories. So when you look at kind of video games, they had a plus 2.03 for internalizing T-score. In social media use, the increasing group had a plus 1.27 and a plus 1.05 T-score for internalizing symptoms as well and externalizing symptoms. So kind of also strong associations with increased risk of these mental health outcomes. The clinical bottom line is that I think that this trial or this study really kind of gave credence to a conversation that I have in the office almost on a daily basis. And that's to parents, like, what is your kid doing with social media at this point? Like, what's their screen use? What's their FaceTime? And what's their time on Facebook and these other apps? And I think this finally gives like a scientific backing to a feeling that we've always had. What do you think?
Well, I know this paper inspired me to launch the screen time app on my phone and become horrified with my screen use and really try to make a change. So I don't know if it changed my medical practice, but it changed my personal behavior.
Yeah, I talk about it all the time, and it's actually refreshing. It's tough being a parent, right? You're a parent, I'm a parent. I think sometimes, you don't want to be the bad guy as the doctor, but I think that sometimes initiating the unpleasant conversation kind of almost gives the parents an out.
Yeah.
And when I bring it up, they're almost relieved that I brought it up. And then they kind of jump in to talk about it. So it's kind of interesting. It's also like the same when someone brings me their 90-year-old relative that they don't want driving. Like Dr. Keenan. I'm like, I appreciate that. I appreciate this visit.
Yeah.
So the clinical bottom line here is adolescents with high or increasing addictive screen use are at significantly higher risk for suicidal thoughts, behaviors, and mental health symptoms. So I think we need to be monitoring these at-risk youths and counseling accordingly.
Yeah, agreed. I heard an interview with an expert on, phone use and adolescent psychology, and she said that she didn't think you should get a smartphone until you get your driver's license. That's when you should get your first phone. Before that, you could have a flip phone if you need to for communication.
I'm an adult and I see bad behaviors on myself with it. It's just too easy to get on there. And this, it's just a bad thing in many regards.
Well, we didn't grow up with it, or I didn't grow up with it. So I'm vulnerable. My children are more inoculated. They actually probably do better than I do. All right. Next article. Number 65, Varenicline and Bupropion for alcohol use disorder. This was a trial published in Lancet Regional Health in May of 2025 about Varenicline and Bupropion in combination and alone for alcohol use disorder. So as we know, treatments for alcohol use disorder are only partially effective. There's a real need for additional medications, especially for patients with opioid use disorder on buprenorphine and methadone because they can't take naltrexone. There are 2 positive studies already on varenicline in a subpopulation of people with alcohol use disorder, as part of smoking trials. And there's 1 study on varenicline plus naltrexone in that same population. But there have been no studies at all on varenicline plus bupropion for alcohol use disorder. And so this is a kind of a landmark trial. This was a randomized controlled trial comparing varenicline 1 milligram twice a day and bupropion 150 milligrams twice a day, both combined or individually, and comparing it with placebo to reduce alcohol consumption. It was pretty big, 384 people, and they did a 1-week titration period. And then they continued the medication for 12 weeks. So you either got varenicline plus placebo, bupropion plus placebo, varenicline plus bupropion, or placebo plus placebo. So there were 4 arms in this trial of 384 people. Primary outcome was self-reported drinking days and biochemically confirmed drinking days, looking at phosphatidylethanol concentration in blood, which correlates with recent alcohol consumption. I thought it was really good. It was strong. It was randomized. There were 4 treatment arms, double-blinded, placebo-controlled. Outcomes were good, both objective and subjective, and it was clinically relevant. They reported adverse events. There was a pretty high dropout rate. 120 of the 385 people didn't complete the full protocol. And the other problem I had was that 12 weeks seemed kind of short. Although in studies of alcohol use disorder treatment, this is standard, but 12 weeks were short. And as I'll talk about in the results, the effect of the medicine began to wane after about 9 weeks. So I would have liked to see it continued a little longer to see if everyone just went back to baseline over time. Bottom line, though, in terms of the results, varenicline and bupropion and varenicline and placebo, those 2 arms with varenicline, reduced alcohol consumption compared with placebo. So effect size was largest if you combine varenicline and bupropion together and they took the medication per protocol. Bupropion wasn't so effective on its own, but when you took it with varenicline, it made the varenicline a lot more tolerable. It reduced that varenicline nausea that people get. So in practical terms, varenicline and bupropion reduced alcohol consumption by 3 drinks a day from a baseline of about 7.5 drinks a day. The placebo arm, they reduced their alcohol use by about 1.5 drinks per day from that baseline of 7.5 drinks per day. This improvement was slightly greater in the per protocol analysis, of course, if you actually took the medication. There were very few adverse outcomes. Varenicline caused nausea and fatigue. And again, if you took bupropion with it, that really attenuated that nausea. So this is definitely going to help me in patient care. I commonly use varenicline and bupropion, especially for smoking cessation. And it did work for alcohol use disorder and reducing alcohol consumption. The varenicline had the strongest effect. So that's the product I would really focus on. You could even use it as monotherapy. And then if you're having trouble with nausea or they really want something as strong as possible, I would take varenicline and bupropion combined. And if someone smokes, the more the better. So John, have you been able to try this with anyone yet?
I have not. I keep forgetting to reach into this. I have people that I have reasons to give bupropion and varenicline to that also have issues with alcoholism, but I've never initiated this directly for this.
All right. Well, let me know when you do.
Have you?
Yeah, totally. It's because almost all of my addiction patients are on buprenorphine because that's kind of my specialty. But then they also struggle with alcohol. And I've been using other treatments, but I would love something, just something else to try. So yeah, I've tried this. The person I tried it on, it did work. He did like it. But again, it reduced drinking. It didn't knock the drink out of his hands.
So in your study in your office of 100% response rate.
I have 100% success rate in my study.
All right.
I'm gonna publish.
Episode 66, Cigarette Smoking During Recovery from Substance Use Disorder. It's from JAMA Psychiatry, August 2025. This is one of the topics that comes up a lot in my office. I'm kind of like the quit smoking. Some people say it's more of a pest, but I like to think it more of a cheerleader for my patients. The clinical question is, does quitting smoking influence recovery from substance use disorder over time? I think that I'm just so used to hearing everyone, smoking rates in the recovery community is incredibly high. And oftentimes I think there's a perception that that's something that they'll get to eventually. It's not a priority today. It doesn't need to be part of their kind of immediate treatment plan, or it doesn't really add any value to their recovery. So the question is that true, or is it the Z pack of recovery?
The Z pack of recovery.
So the methods, it's a longitudinal cohort study of 2,652 U.S. adults with lifetime substance use disorders, and it's from this PATH study, which is the largest study. It examined within-person change in smoking status and substance use recovery over 4 annual waves. So they actually compared people to themselves, which is very interesting. They controlled for mental health, education, healthcare use, smoking cessation, medications, and also kind of whether they were kind of urban or rural, since that had a strong predictor. When you look at the results, it was actually very interesting what it came up with. Quitting smoking increased odds of substance use disorder recovery. So that's independent of just tobacco use. When you look at the unadjusted odds ratio, it was 1.42, and that was statistically significant. When you look at the adjusted, it was 1.3, also statistically significant. So quitting smoking increased your risk of staying in recovery from another substance. Recovery increased modestly over time, regardless of smoking status. So that was kind of a theme we see often, like that kind of a natural progression for many patients is that they do get better with time, regardless of intervention. Not everyone, but there is a group that just recovers in our absence of our care. Not surprising, better mental health outcomes were also linked to recovery, so that's not surprising to me whatsoever. Although, interestingly, in terms of the odds ratio, better mental health outcomes only had an odds ratio of 1.04, but you had a 1.42 odds ratio for quitting smoking. So kind of suggesting that the effect of smoking cessation was actually kind of stronger in this study for substance use disorder recovery than better mental health, which is surprising to me. I would have thought that would have been much more powerful.
I don't know, man. Smoking is really bad for your mental health, Like, smoking is bad on all axes. It's not a benign thing. So I think you could do better in a
I'm
lot
not
of areas.
disagreeing with that, but if someone told me, like, I'm going to give you better mental health, you would think that would be pretty powerful for most of our disease states, not just kind of substance use disorder.
Yeah, I think.
Education, healthcare use, and cessation medications actually did not significantly influence recovery here in this study. So kind of clinical bottom line, quitting smoking supports recovery from a substance use disorder. This study really kind of supports my existing practice where I kind of view someone more from a comprehensive health standpoint. And while oftentimes people, when they first meet me, their priority is kind of more of a, quote, stronger substance use issue, I do address all of their kind of medical comorbidities and other substance use disorders. And I always tell people that tobacco use is the most common cause of death for someone with like a substance use disorder, right? So most common cause of death for someone with opioid use disorder is tobacco-related health complications, not IV drug use. So I think I think we've given smoking a little bit of a pass here over the years.
Agreed. Well, I think this is really interesting. It supports my nagging of people to quit smoking also. I'm a big nag in my clinics as well. I won't let it rest. All right. Article 67, rapid start injectable buprenorphine. So this is all the rage. People have been talking about this at conferences this year, basically giving these long-acting injectables without a run-in of sublingual buprenorphine first. So in this era of fentanyl, initiating buprenorphine has become more difficult. It's higher dose, it lasts longer, there's a higher rates of precipitated withdrawal, and getting people onto sublingual buprenorphine just has become a tricky thing to do it safely and to do it without too much discomfort for the patient. So we're always looking for new ways to get people started. These long-acting injectables, which are brand name Brixadi and Sublocade, are being used more and more. And this study described one protocol for overlapping these injectables with the fentanyl you might be using to initiate rather than initiating with sublingual buprenorphine first. It was a simple study, just descriptive. It was done with patients who were injecting fentanyl, had 95 patients from a low barrier clinic serving mostly unhoused people. And the protocol basically overlapped the injectable buprenorphine with the fentanyl they were using. So patients didn't have to experience withdrawal prior to getting their first dose. The protocol was on day 1, you got a weekly 8 milligram injection. Day 2, you got a weekly 16 milligram injection. Day 3, you got a monthly injection, either 128 milligrams or 300 milligrams, depending on the brand you chose. And you continued your fentanyl, and ideally you stopped your fentanyl after you got that monthly injection. And they were given medications for withdrawal symptoms. So 3 shots, 3 days, each one a slightly higher dose. And you could take your illicit fentanyl if you wanted to, and were even encouraged to use it if you had symptoms of withdrawal. They looked at how many of the patients were able to complete this initial 3-day protocol and how many returned 4 weeks later for their second injection. So keep in mind, this was just a study about treatment retention, not necessarily efficacy or tolerability of the protocol. I thought it was a strong study, big group of patients, almost 100 patients for a novel protocol. The only downside is that it might not be generalizable to people like me working in a traditional office. They had a strong outreach component. They would go to where the patients were, in homeless encampments or tiny house villages on the street. They were going out to the patients with the injections. And they also have better pharmacy access. For me, it can be 2 or 3 days, sometimes 5 or 6 days from when I order an injection to when I actually get it, just because of the delivery schedule in our rural area. They could get the medication within 24 hours and sooner if the doc or someone from the clinic was willing to walk to the specialty pharmacy and get it, which was down the street apparently. So they just have better access to medications, and they were able to put this 3-day protocol into place, which I'm not necessarily able to do. So that's a little bit of a limitation for me. Also, they didn't really talk about how patients felt about the process or whether they had precipitated withdrawal. But in general, I thought it was a good study. So of the patients, 95 people, 90% of them started the protocol after choosing it. 75% completed the protocol, so got all 3 shots, and 64% returned a month later for a second monthly long-acting injectable. So that's great news. 64% of people really got fully started on treatment with this protocol. And this is a very difficult to reach group. And the barriers are really just administrative, not clinical. So I don't have the access to put this protocol into place in my clinic. However, I have been talking to some other doctors who have other protocols that are even simpler for rapid acting injectables. And I definitely think I'll maybe use this in select patients. So I'll deploy it for the right patient. Maybe not this exact protocol, but a similar one. How about you, John? What do you think about giving these injections cold without the sublingual buprenorphine first?
I think it's one of those things where certainly it's one of those things that we don't really have to do that I once thought was like dogma, right? It's funny how we've gone on longer here, the kind of the loading periods have decreased, not surprisingly. And then also the need for these kind of wash-in periods has also kind of gone away. And then even how we store them has really changed. So it's funny, like, you kind of study these in like this ideal state and then realize that these aren't clinically significant factors. I think the same with that you describe here is that I don't really have a niche for this at my current practice, mostly because it takes me a couple of days to get the product. We don't have buy and bill where, we have it on stock just to give someone when they come in. And the tough part is that these medications are so expensive that I know when we had discussions with our organization that they're just terrified of even one sample going bad, just how much we would lose with that. So like they don't really want to do buy and bill because it's hard. So unless you have some high volume clinic that can afford to keep this on stock, it's probably not a great option.
Although, as I said, there was another doc had told us about a protocol just doing a single 300 milligram injection, and that's that. So you only have to order one. So I might try that with patients instead.
Yeah, so have to get it is the thing.
Yes. Have to do some sort of initial assessment.
I feel like I would actually attempt that. But the problem is I feel like by the time you come in here and I talk to you the first time, you have a couple of days. Or not that I'm trying to kind of do a lead in, but oftentimes out of necessity I am.
Right, because the injectable is just not available that first day.
Yeah.
Right. Well, if either of us do it, we'll let you all know.
Yeah. All right, episode 68, behavioral therapy as an adjunct to buprenorphine treatment for opioid use disorder. And this is from JAMA Network Open from August 2025. The clinical question was, does adding behavioral therapy to buprenorphine with medical management improve retention, reduce opioid use, or enhance functioning? So the methods, this was a pooled analysis of 4 separate randomized control trials totaling 869 adults. It compared buprenorphine and medical management alone versus the same plus behavioral therapy. Interestingly, in this trial, a couple things, when they talk about medical management, did have a relatively more intense clinician counseling component that I think some of our patients get. So the APP or the doc kind of provided more counseling and guidance at that visit in the office. And then when you look at the behavioral therapy subtype, it was mostly cognitive behavioral therapy. And I think that's interesting because there was just more options out there than just cognitive behavioral therapy that have been proven to be efficacious in this population now. So I think that is a somewhat limitation here. The outcomes were opioid use, retention at the 12-week mark, and functioning, which they kind of assessed through the ASI. Results here, there was no significant benefit from adding behavioral therapy. When you look at number of opioid-free weeks between the group with and without behavioral therapy, it was 7.16 versus 7. That was not statistically significant. In terms of weeks retained on buprenorphine, 10.29 versus 10.21, so almost exactly the same. Functioning in all domains showed no meaningful improvement with adjunct behavioral therapy, which I find surprising just because that helps so many other things with mental health comorbidities, which is typically high in this population. And then I found most surprising the subgroups of PTSD, depression, chronic pain, heroin use, they did not benefit more. And I think that was surprising to me mostly because I know PTSD and depression improve with behavioral therapy, and chronic pain, that's a new area, kind of pain reprocessing behavioral therapy can be very beneficial there. So I'm really surprised that we have good data that those groups benefit from it without opioid use disorder, but then you add in the opioid use disorder and there wasn't a benefit. So I thought that was surprising.
Do you think the opioid use is just so potent that it kind of overwhelms your ability to benefit from these behavioral treatments?
It's tough to say. I mean, the trial duration, it's relatively short, right? They're looking here 12 weeks. I feel like I've learned this. It's just with patient care, even my patients without a substance use disorder, I'm playing a long game here. So 12 weeks is not that meaningful of an endpoint for me in the big scheme of things. So I think it's a start. I'm just not sure. It's hard for me to really kind of knock on this. I think we've talked about this before, just because I feel like I have so many patients that have told me how beneficial this has been for them in one way or another. And yet I feel like every time we review one of these, that there's no effect that's statistically significant.
I wonder if it's just when we treat chronic pain in people with opioid use disorder, nothing works for them when they're on these opioids, and finally they get stabilized, and all of a sudden, meloxicam is super effective when it wasn't before.
Yeah. Maybe.
So I wonder if maybe behavioral treatments are more effective to people after they're stabilized and they're looking for something more than just getting off the opioids.
That's an interesting theory. Maybe they're not as receptive.
Or they just can't, they can't they can't do anything but focus on getting off the opioids.
Yeah, so the clinical bottom line here is this trial shows that buprenorphine combined with standard medical management is typically sufficient. Adding behavioral therapy did not improve treatment retention, reduce opioid use, or enhance functioning, despite its valued role within the recovery community. I really think that I take away that I think we need more research into finding out what's the secret sauce here. Where does this play a role? I think it does play a role, and so I know we've talked about this before. I'm a firm believer. I think it does somewhere. I think we just need to figure out what group at what time frame really benefits, and maybe it's not everyone.
Right. True. All right. Number 69, Cytisinicline for smoking cessation, the ORCA phase 3 replication randomized clinical trial. So this features a new old medication for smoking cessation called Cytisinicline. This was a trial that was done to get FDA approval for this product to be released on the market, and it was approved, and it'll be on the market mid to late 2026. So everyone be ready to use this when it becomes available. So this is a medication called Cytisinicline. It's also known as Cytisine, and it's a partial nicotinic agonist, the alpha-4 beta-2 nicotinic acetylcholine receptor agonist. It's been widely used for smoking cessation in Central and Eastern Europe for over 50 years. And no one brought it to market in the US just because no one wanted to pay the money to do the FDA approval study for a generic product where there wouldn't be patent protection. So no one ever brought it to market. And this group renamed and redid the dosing schedule. So came up with a novel dosing schedule that's pretty different from how it's used traditionally. And we're able to get a patent on that, on the product. And that inspired them to do the study, and they got FDA approval. So the clinical question is cystinicline effective for smoking cessation? It was a randomized, placebo-controlled, blinded trial comparing cystinicline for 6 weeks, cystinicline for 12 weeks, and placebo. It was a pretty big study, 792 people, and they got, as I said, the medication for 6 weeks, for 12 weeks, or a placebo for all 12 weeks. They also received pretty intensive behavioral counseling. They got 14 behavioral counseling sessions about smoking cessation. Outcome was smoking abstinence, which was biochemically verified with carbon monoxide levels. They also looked at cravings through the questionnaire of smoking urges, and they looked at adverse events, which is important because this is a new product on the market, on our market anyway. They did the trial for 12 weeks, and I thought it was a valid trial. It was big, it was randomized, blinded, placebo-controlled, all the good things. They worked really hard to do good reporting on the adverse events. My only real complaint is that the study was so good that I don't really think it represented my real world clinical setting. They had excellent follow-up, 14 behavioral support sessions. I wouldn't really have that in my clinic. So I don't think it'll work as good when I deploy it in the real world setting. So let's talk about the results. Cystinicline is effective for smoking cessation at both the 6 and 12-week treatment courses, and the benefits extended through 24 weeks, even after they stopped the medication. The cystinicline mitigated nicotine cravings and nicotine withdrawal and had minimal adverse effects. The results were clinically and statistically significant. They used both subjective and objective measures of smoking cessation, and there were minimal adverse events. So really great data, really great outcomes here. The primary outcome was smoking cessation achieved by an amazing 30% in the 12-week cystinicline group. The placebo achieved abstinence at about 9%. And even after they stopped the medication at week 24, they've been off the medicine for 12 weeks. About 20% were still abstinent from cigarettes at that time, compared to 4.2% in the placebo group. The other thing that was interesting is even, if you look at the trajectory in the study, the abstinence rate just continued to rise throughout the 12 weeks. It didn't appear to plateau. So I feel like if you continued the medicine longer, the overall percent of people who quit would continue to go up. There weren't a lot of adverse events, just insomnia, some abnormal dreams, some headaches, similar to Varenicline. So in summary, this is a new, effective tool for smoking cessation. I'm definitely putting it in my arsenal. The new dosing regimen is easier than the traditional one, which is sort of a complicated 25-day taper. And I don't know if it's more effective than other treatments. It'll probably be a little more expensive, at least at first. But if patients want to try something new, I'll be happy to try it. John, do you think you're going to try this for smoking cessation? Since we talked about how you're a smoking cessation cheerleader.
Yeah. I think I can always use more tools in that toolbox, right? There's not much there right now.
Right. The big question is, how much is it going to cost? We shall see.
It's interesting. Yeah. Medicine that's not new, now just new in this country. How much is it going to cost?
Yeah, that'll be interesting.
So our wrap up here at the last one. So this is episode 70, prescription stimulant use, misuse, and use disorder amongst U.S. adults age 18 to 64 from JAMA Psychiatry from June 2025. The clinical question is, how common is prescription stimulant use, misuse, and prescription stimulant use disorder among U.S. adults age 18 to 64? And what factors are associated with misuse and prescription stimulant use disorder? So methods, this was a cross-sectional study of 83,762 adults using multiple databases, this IQVIA prescription tracking database, which accounts for most prescriptions in the United States, and the NSDUH surveys from 2019 to 2022. Prescription stimulant use assessment included both misuse and prescription stimulant use disorder. Misuse was defined as using in a manner other than prescribed, while prescription stimulant use disorder was assessed via the DSM-5 criteria. And this was a newly added assessment for the NSDUH, so it's kind of a new category they were looking at. The survey examined demographics, mental health comorbidities, substance use, motivations for misuse, which is a very interesting area to look at. And then, like I said before, I don't think it could be any trial at this point without saying COVID-19 impact. The results were, interestingly, in terms of prescription stimulant use. So in the past year, 7.5% of users in this trial were using some form of prescription stimulant. So that's a lot. It's almost 1 in 10 adults. Dispensing, surprisingly or not surprisingly, increased across all groups. So there's an average increase by 1.8 to 2.6% per year. The largest rise was in women aged 35 to 64. And that went from 1.2 million to 1.7 million prescriptions, which, in some regards, that's actually kind of a positive thing, since this has classically been a group that we've talked about that we've underdiagnosed ADHD. And so I'm wondering if that's just a reflection of us kind of increasingly recognizing that diagnosis in that group. In terms of stimulant misuse, among users, 25.3% misuse stimulants during this. So let me kind of repeat that one more time. Among stimulant users, 1 in 4 misused. The highest misuse was women less than 25, so it was 36.8%. The lowest was women 35 to 64, so and that grouped, I guess, 25 to 35 with women in between, is kind of a watershed area there. Misuse was strongly associated with depression, suicidal ideation, nicotine dependence, another substance use disorder, and stimulant and cocaine use. So that was very high there. Interestingly, I really always want to understand why more so than the what. And when you look at the why, like why were people misusing their stimulants? Almost 2/3 of them was for alertness and concentration. So it was some attempt by them to treat symptoms of inattention and concentration. And most of these group, like 68%, misused less than once per month. In terms of frequent misusers, greater than 6 days per month, they often obtained stimulants from family or theft. And that was kind of the misuse part of it. Going on to like the group that actually developed a substance use disorder, so prescription stimulant use disorder, about 9% met criteria for prescription stimulant use disorder, with most meeting mild criteria. There's a strong link between meeting criteria for substance use disorder and misuse, so it's not surprising, kind of reflecting that this is somewhat a spectrum, which is what we all kind of think of. Also, very surprisingly, when you look at the actual stimulant, amphetamines had higher risk than methylphenidate for misuse and use disorder. So it's 31.5% versus 10.2% for misuse, and 11.2% versus 5.1%. So kind of amphetamines over double to triple the rate of misuse and mean criteria for use disorder than methylphenidate. And I find that surprising, just because I feel like I've always been taught by my like psychiatric rotations that like that was one to avoid because of the short acting nature, that it was more likely to have a misuse. And I know there is extended release ones as well, but I was always told it's just a shorter acting one and was kind of more cocaine like.
Do you think it's just demographics? Like I see most people on long acting, and I think of like kids being on the short acting.
Well, it doesn't say short or long acting though, right? So it's amphetamines versus methylphenidate, right? So some of the methylphenidates are extended release too. So it's not saying anything about extended versus immediate release. It's just talking about kind of the stimulant category of drug. I always had a pediatric psychiatrist that taught me in residency. Always, he drew out a tree. There was the stimulant tree. And there's only 2 main branches. It was the amphetamines and then methylphenidate. And I always, to this day, I still think of the tree. And I use that analogy a lot.
It's not a tree. It's just a Y with 2 branches.
I don't know. It sounds sort of like it's like a birch tree. And then your non-stimulants are like mushrooms growing on the ground somewhere around there.
Right. Exactly.
I don't think the COVID-19 impact is even really worth mentioning. It seems very confusing to me. So basically, people during COVID-19 that went to telehealth, they had higher rates of use disorder, but lower rates of misuse. So I'm not sure what to kind of make of that yet. I still think the jury's out for telehealth for some of this. I think that it only takes a couple of bad players to really flood the market with unnecessary stimulants. And I think we saw that with some of these pop-up organizations.
Yeah, for sure.
Yeah, and some of them, it's bad when Walmart's not filling your script, right? I feel like
Yeah.
that's always a metric that you're in trouble, is if the Walmart's like, not this guy.
Although I don't know, Walmart's kind of going rogue and like making up their own rules. So I've had some Walmarts refuse to fill some of my scripts for reasons that seem, sketchy to me.
So the clinical bottom line, prescription stimulant uses rise in the U.S., with 1 in 4 users reporting misuse and about 1 in 10 developing prescription stimulant use disorder. Amphetamines are higher risk than methylphenidate based upon this information. Oftentimes, people are misusing for concentration and alertness, so almost to treat symptoms that they are associating will benefit from this, not necessarily for like a euphoric effect. And development of a use disorder is not surprisingly also linked to other substance use disorders and mental health issues. I think that this really article to me just kind of put a number with a feeling. Like I feel like for a while I felt like that these scripts are rising, that, I feel like I go to like 2 grand rounds with behavioral health, and it's like either that I'm underdiagnosing and undertreating ADHD, or that, we're overtreating. And I do feel like at times I do question if we're overtreating and overdiagnosing, even though I send people for neuropsych testing. I think this though shows us that, 1 in 4 are misusing. So, I mean, that's its own separate entity. But my bigger concern is this 1 in 11 or 1 in 10 that's developing a use disorder from a prescription that I'm giving them. And actually that really mirrors, I know that not the death part of it or the mortality, but 10% is about the rate of people that are on prescribed chronic opioids that develop opioid use disorder. So it's a very similar number.
Right. Yeah, and that's devastating. I mean, these use disorders can disrupt your life, can land you in jail, you can lose your health, your freedom, everything when you develop a substance use disorder.
Yeah.
So on that note, we made it in under an hour, 55 minutes. I'm looking at our time clock. Thank you to everyone who stuck with us. And it's not even 10 p.m. So John and I, we still have a long evening to go of fun, right?
Yeah.
Yeah.
I'm playing catch up for Stranger Things before I watch the final episodes.
There you go. It's a good activity. I think I'm just going to go to bed. Well, thank you, everyone. Thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about any of our articles included in a future episode, please send us your comments on social media, on email, join our Facebook group, comment on Spotify or YouTube. The links are in the show notes. Our original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from My Cares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation. Have a great day.